Welcome, everyone. This is Marissa. I am the clinical director for children with diabetes. Really excited to be here with Dr. Bote Bruinsma. Yes, I know it's not the correct way. From Vertex. Our friends at Vertex are going to share some information about their current studies, and they will be joining us at Friends for Life Orlando in just over a month. And we're hoping Dr. Bote will join us down there sometime when he wants some extra warm time. So I will go ahead and read your introduction and then let you get to it. So Dr. Bote Bruinsma is the Senior Medical Director for VCGT Clinical Development in Type 1 Diabetes. He joined Vertex in 2018 and has worked on different disease programs at Vertex. Since 2020, he has led the VX880 clinical development program for type 1 diabetes. And he worked in clinical development and medical affairs at SIO Gene Therapies and Harvard University in the Department of Surgery. He holds a PhD in liver preservation of transplantation and obtained his MD at the University of Amsterdam. And actually, before I let you get into it, I wanted to remind everyone that's online and tuning in live, you can submit questions via the Q&A feature or the chat, and we will do our best to get to those at the end. And if not, we can follow up with you after the webinar. So, Dr. Bruinsma.
Thank you very much, Marissa. Are you going to pull up the slides?
Yep.
Excellent. Thank you for that kind introduction, and thank you and CWD for the opportunity to share some of the work that we're doing at Vertex on stem cell-derived islet therapies in type 1 diabetes. I'm very grateful for this opportunity as we look to explore opportunities to share this innovative clinical trial work in type 1 diabetes with the broader community. So what I'd like to do today is start off with a little bit of background, kind of setting the stage for why we're conducting these studies to begin with. Obviously, many of you are aware of the unmet need in type 1 diabetes, but just to level set with a foundation, I'll go into some of the details and some of the data to support that. And then I'll focus more on what is being done in the field of islet cell transplantation, and specifically at Vertex with stem cell-derived islets as a potential therapy for type 1 diabetes. Now, before I get into that, just an important disclaimer here is that these therapies are all investigational in nature, and they're currently in clinical testing. And for that reason, they are not approved for clinical use by any regulators and not in the US either. So the FDA has not reviewed this, and it is not an approved therapy. So next slide, please, Marissa. So just to set the stage, which I think many of you are very well aware of, people with type 1 diabetes are constantly managing the balance between the challenges associated with the disease, as well as the challenges associated with the treatment of the disease, where the treatment results in a continuous balance between what's called hypoglycemia or low blood sugar and hyperglycemia. Of course, we know hyperglycemia from type 1 diabetes itself is not untreated, will result in microvascular and macrovascular complications. But on the other side of the spectrum, low blood sugar or hypoglycemia can also have a substantial impact on patients' health. We'll talk about some of the details of hypoglycemia in an upcoming slide, but in a very acute way, low blood sugar or severe hypoglycemic events can be critically dangerous to patients, resulting in hospitalization and even mortality. They can have a substantial impact on patients' quality of life, cognitive impairment, and other morbidity associated with low blood sugar. So if you click one forward still, there is in between this a significant burden in managing type 1 diabetes, which is balancing hypoglycemia and hyperglycemia, which is, of course, the treatment itself, but also the cognitive burden, distress, and stigma associated with that. Next slide, please. So, of course, it's important to just stand still with all of the advancements that there have been over the last several decades when it comes to the standard of care for type 1 diabetes therapy, both on the glucose monitoring side as well as the insulin administration side. We've advanced on the left-hand side from self-monitoring glucose, blood glucose, which you had to do a number of times a day before food, exercise, bed, and sometimes even in the middle of the night, to the more readily available continuous glucose monitors, which allow for much more frequent measurements and alarms associated with high or low blood glucose measurements, which nowadays can be conveniently linked to phones, watches, and even the pump on the other side, which has replaced for many patients multiple daily injections with a more continuous and tailored administration of insulin therapy. And then even more recently, the two have come together in what's known as hybrid closed loop systems or automated insulin delivery, the first of which were approved in 2016, which integrates the information from the continuous glucose monitor and informs the pump on what insulin is required to maintain appropriate glucose levels. All of this has resulted in substantial improvements in glucose management and in the management of diabetes overall. But despite these technological advancements, the majority of patients are still actually not achieving optimal glycemic control. And as you can see here, for various modalities that patients might be using, ranging from daily injections all the way to CGMs paired with pumps, many patients, and this is on average shown by age, many of patients don't reach the recommended targets for HbA1c, which are generally at around 7%. Overall, if you can just go back one, Marissa, before we go forward. Overall, there's varying literature on this, but the general consensus is that the majority of patients do not achieve these recommended targets, and that they can be as low as 20%, depending on the population and the technology that's available to them. Next slide. So overall, there's a range of different morbidities, mortalities, and impact of quality of life that we need to consider when addressing the unmet need in type 1 diabetes. Starting on the left-hand side with the practical burden, of course, constantly monitoring glucose levels and adjusting therapy to fit within those hypoglycemia to hyperglycemia ranges, the management of blood glucose level testing and insulin administration. And if that's not done correctly, the morbidity and impact on life expectancy that is associated with that, where data still suggests that type 1 diabetes is associated with a reduction in life expectancy, but most importantly, the quality of life of patients is significantly impacted by not just the disease, by the management of the disease as well. Next slide, please. So if we focus a little bit more on the low end of the spectrum, I talked already a little bit about hypoglycemia, which, as I'm sure many of you are aware, is the result of an excess of insulin in the blood, which results in low blood sugar or hypoglycemia, which normally will be felt as symptoms like tremor, shakiness, sweating, nervousness, and is a signal for the patient to treat that hypoglycemia with sugars, or even if needed, a more therapeutic option like glucagon administration. However, what can happen if you have recurring or long-standing events of hypoglycemia? Patients can develop what's called impaired awareness of hypoglycemia, where you don't actually feel those symptoms of hypoglycemia anymore. And as you can imagine, if you don't feel those symptoms of low blood sugar anymore, you're at risk of low blood sugar going even lower. And that's when a phenomenon occurs called severe hypoglycemic events. A severe hypoglycemic event, as the name indicates, is a hypoglycemic event that is particularly severe because it is associated with symptoms, but a patient becomes so incapacitated by the symptoms because of loss of consciousness, visual disturbances, behavioral disturbances, that they're unable to treat the event themselves. Now, you can imagine if you don't have someone near you that is able to treat these events, this can be particularly problematic and lead to loss of consciousness, even coma, and death in the more severe cases. So these Severe hypoglycemic events are acutely dangerous and are something that is associated with morbidity, mortality, and of course, patients that experience these have an extremely high unmet need that needs to be addressed. Next slide, please. So here's some additional data that I said I'd share on the unmet need in this patient population, looking specifically at mortality associated with these hypoglycemic events. So overall, in patients with type 1 diabetes, hypoglycemia is associated with a twofold increased risk of mortality. And as you can imagine, in younger patients in particular, these hypoglycemic events actually result in approximately 10% of all deaths in patients under 10 years or under 40 years of age. You can see that in a little bit more detail on the left-hand side, where in the purple bar, you see patients with out severe hypoglycemia, and then on the right-hand side, in two different patient populations with or without cardiovascular disease, an increased risk of mortality amongst patients who have at least one episode of hypoglycemia. And you can see that that is substantially increased as a result of this condition. Next slide, please. So what do we do about it? So you may have heard of islet cell transplantation previously. Now, islet cell transplantation is not actually something new. Islet cell transplantation is the process of isolating the islets, which are the cells in the body that produce insulin, from a donor in the same way that you would receive a donor kidney or donor liver for transplantation. And these cells are isolated, they're removed from the donor pancreas, and they can actually be transplanted into a patient with type 1 diabetes. Now, like any other transplant, it requires immunosuppression because these cells are foreign to your body. And like any other organ transplants, you need to prevent that these cells are rejected. But when this is done, when these islets are administered along with concomitant immunosuppression, it has been demonstrated with donor transplantation that islet cell transplants can improve glycemic control, reduce these severe hypoglycemic events that I mentioned, and even when the outcomes are optimal, reduce or eliminate the requirement for exogenous insulin altogether, which of course substantially improves the quality of life of patients. Now, this was first published on several decades ago now, starting in a group in Edmonton, and since then it has been applied in multiple regions across the United States, Canada, and Europe, and with similarly successful outcomes. Next slide. But there are some important limitations associated with these donor islet cell transplants. Of course, like any other organ transplant, we're limited in the supply of these cells by the availability of donor organs. Someone needs to donate their pancreas. The pancreas needs to be of sufficiently good quality that sufficiently good, high-quality islet cells can be isolated from these pancreas and can then logistically be transplanted into a patient who is at need that has type 1 diabetes. What that results in is a waiting list for these organs to be available for isolation and transplantation, and also varying results. So depending on the quality of the organ and the quality of the islet cells, the outcomes will differ. And of course, importantly, and it shouldn't be underestimated, there is also the requirement for immunosuppression, which of course also has risks associated with it. For example, the risk of infection. Next slide, please. So what are we trying to do about that? An alternative to isolating cells from a donor pancreas is actually to manufacture cells. And one way to do that is by using stem cells. Stem cells are cells that have an unlimited multiplication capacity. So you can take a single stem cell and make an unlimited number of cells from them. And Vertex has technology that has been shown where we've been able to show that we can take one of these stem cells and so-called differentiate them into pancreatic islet cells. And if we can do this at scale, and we can do this consistently, then we're able to consistently supply an unlimited supply of islet cells that can be used for transplantation in patients that were in patients that are similar to those that were previously eligible for donor islet cell transplantation. Next slide. So we're currently studying these cells in a clinical trial, which is called the FORWARD trial, which I'll talk about in a little bit more detail. But overall, what we're trying to do in this trial is evolve the treatment for type 1 diabetes beyond the current standard of care, which, as we discussed, is currently based on insulin, with or without technology to support that insulin therapy, where we're using stem cell-derived islets in combination with immunosuppression in a patient population that has that high unmet need of recurrent severe hypoglycemic events that can be acutely life-threatening. Next slide, please. So a little bit more detail about this ongoing study. This is a phase 1/2 study that is aimed at evaluating the safety and efficacy of a patient population with a high unmet need, where the benefits of treatment outweigh the potential risks associated with participating in the study, including immunosuppression. So the primary objective of the study is to establish efficacy of this investigational cell therapy in these patients that have a combination of impaired awareness of hypoglycemia and recurrent severe hypoglycemic events. This is a single-arm study, which means that all patients in the trial will receive treatment. It's divided into 3 parts, where we escalate and evaluate different things at different stages of the study. And the current sample size of this trial is 17 patients that will be followed for a total of 5 years in this study, after which we're planning to follow these patients for an additional 5 years in what we call a long-term follow-up study. Next slide, please. So just to get into a few of the eligibility criteria to participating in this study, these are male or female patients, adults up to 65 years of age. Patients need to have at least a 5-year history of type 1 diabetes. And importantly, as I mentioned, patients need to have at least 2 documented events of severe hypoglycemia in the 12 months prior to enrollment, where severe hypoglycemia is defined as symptoms associated with hypoglycemia or low blood sugar, documented low blood sugar or recovery of a low blood sugar after carbohydrate or sugar administration. And then importantly, and this is key to the criterion, is that patients with a severe hypoglycemic event were unable to treat themselves and required the assistance of another to treat the event. Patients eligible for this study at this time need to have a specific blood type that is aligned to our cells. So blood types are currently limited to blood type A or AB, and that's something that will be tested if a patient is screened for the study. And then we also ensure that patients have experience with continuous glucose monitors for at least 3 months prior to screening for the study, and they'll continue on a continuous glucose monitor for the duration of the study so that we can appropriately monitor patients' glucose levels. Unfortunately, advanced complications of disease are currently excluded from this phase 1/2 study. And then, of course, patients are committing to comply with the study's instructions and assessments that are done. So there's a little bit more information that can be found at this link, where we've published some of the details on the trial in this clinicaltrials.gov posting that is publicly available. Importantly, though, just to add, this is just a subset of key eligibility criteria. If a patient is interested, they will be screened at one of the clinical trial sites, of which there are 9 in the United States, really geographically spread out through the country. And a patient would undergo screening assessments to determine their formal eligibility for the study. Next slide. So just a few details on what it looks like to participate in a study like this. So a patient will come in, as I mentioned, for a screening visit where tests are done to ensure that a patient is appropriate for the study, but also that it's safe for the patient to participate in the study. And if all of that is passed, then the treatment with these islet cells will occur approximately within 90 days of that initial screening visit. Before the actual procedure, a patient will come into the hospital a few days before. They'll start on their immunosuppressive therapy, and then they'll be monitored. Some final tests will be done, and then the infusion procedure will take place on day 1 of the study. And then after that, the cells are implanted, And for the duration of the study, patients will be required to take immunosuppressive medication. Again, this is required to ensure that the body doesn't break down these cells or reject these cells. As I mentioned, you'll have to wear a CGM device through the study, which the sponsor provides. And then the duration of the study, as I mentioned as well, is approximately 5 years. And then there's a certain cadence of visits where a patient will come into the clinical trial site for certain assessments. In the first year, that's a little bit more frequent. Patients are seen approximately every month, either at the clinical trial site, or in some cases, it can be done remotely through telephone. And after that, it's on a 3-monthly cadence. So it starts to become a little bit more aligned to what a normal endocrinology follow-up would be. And then just the last thing to note on study participation is that since this is an investigational study that is sponsored by our company, all study procedures and logistics associated with participation of the study are covered. Next slide. So what does the infusion process actually look like? So the infusion process is that the islet cells are delivered into the liver, and that's done through a small surgical procedure or a procedure by an interventional radiologist who can do this what's called percutaneously by catheterizing the portal vein of the liver. And then after that is done, the infusion of these cells occurs slowly over approximately 60 to 90 minutes. And after that, the procedure is completed. And of course, the patient is closely monitored for any potential complications associated with the procedure. Next slide. And then I'll just conclude with a couple of resources that we have available. I already cited the clinicaltrials.gov posting, which is a public posting of really any clinical trials that are available, but our clinical trial for VX-880 is posted there as well. And then there's also a study website that I can refer you to called Type 1 Diabetes Study, or T1D Study rather.com.
Thank you so much. I really appreciate it.
Thank you,
It was
Marissa.
absolutely lovely to get to know you and get to know Vertex a bit more. And we look forward to having you all at Friends for Life in just about a month. So
Likewise. Thank you, Marissa and CWD for the invitation to speak today.
absolutely. And if anybody has any further questions, feel free to reach out on the Children with Diabetes website. We'll do our best to get you answers to your questions. Thanks for tuning in.
Thank you.